So mechanical thrombectomy, what are the options? So this is the first case. 30-year-old woman, she's a professional, she's I believe a lawyer, African-American, 2013, history of a right calf DVT, so a prior DVT. 2 weeks before she saw me, she began feeling some back pain, progressed to left leg whole pain and numbness and swelling following a 10-hour flight, I believe it was from Europe. She's also on OCPs. Doppler showed thrombus extending from the common femoral vein to the calf, and we got a CT venogram. This is what it looks like. So here the arrow is pointing to the lower IVC, and you see this thrombus right there. You see thrombus in the left external iliac vein, and then all the way down to the common femoral vein. So very clearly, this is at least an iliofemoral DVT. I spoke with her. We had the ATTRACT trial results at this point, and she sort of fit the perfect sort of milieu for the patient that would actually benefit from early thrombus removal. So we discussed it, and she was interested in proceeding with an actual intervention. So here you can see that we've accessed her popliteal vein. This is what I call the glide wire or the Benson wire test, where it folds over and just goes up, and that tells me it's pretty acute thrombus. And you can see this Tram track sign here where there's thrombus in the middle and there's this dense contrast around it. And then spindly collaterals. This all speaks to the fact this is a pretty acute DVT. And then, so this is the point of it, of this case, which is the mechanical part of it. This is angiojet rheolysis, so pharmacomechanical thrombolysis. So this is what was used in the ATTRACT trial. One of the instruments that was used. Basically, what you do is you put it into a power pulse mode, and you pulse it in over the length of the thrombus. You let it sit for about 30 minutes, and the amount of TPA you use is about 1 milligram for every 3 centimeters of clot. That was the guidance that the ATTRACT trial gave us. So put that along the length of the thrombus and then waited 30 minutes, and then brought the patient back and put it on thrombectomy mode. So that's the thrombectomy component of this pharmacomechanical device. And then this is what our result was, which you can see there's pretty good thrombus clearance, but then there's this area here where you just do not get very good flow. And this was a pretty static column. So at this point, I decided to actually do some catheter-directed thrombolysis, just put a standard catheter in there. And after 20 hours of infusion, we have a better looking femoral vein and better segment in the common femoral vein. Not perfect, but again, taking the results of the ATTRACT trial, really looking to clear the iliofemoral segment, most importantly. And then given that lesion we saw on the previous slide, stented her, and we had a nice flow. She took her Volta score from before the procedure of about 12 to 15, and now she's a little bit less than 5. As Keith mentioned, I continue to follow her many years after this procedure, although I think it's been a year and a half. So that's case number 1 of a sort of pharmacomechanical approach. Now, the second case is actually a purely mechanical approach towards a large iliofemoral DVT. This guy is 66 years old, has a history of appendiceal cancer, but the chemotherapy was completed in 2018. Did have a history of DVT and PE, had a bunionectomy in February, and he presented to the ED a few weeks later with leg pain and swelling. Physical exam was quite impressive. Left leg was much greater than the right in terms of circumference. He had normal pulses, so we weren't talking about phlegmasia. He was started on heparin in-house, and we were consulted for thrombectomy and thrombolysis. These are his vitals, so he's quite stable. These are some videos I'm going to play for you. And here we're following the IVC, and then it's going to split off, and you can start to see the thrombus and all of this inflammatory stranding around the left and occluded iliofemoral segment, and you can see the difference between this side and this side in terms of the amount of contrast. So this was all acute thrombus. Got to click outside of that. This is his ultrasound. You can see the common femoral vein, the femoral vein, popliteal vein, all of it was out, and including into the soleal. So a big DVT and quite a challenging case. But we did decide to access just below the popliteal vein, and here I'm going to show you some pictures. This is again the Benson wire test, where you send a Benson wire up and it just goes up, and that tells me it's an acute DVT. A little bit higher up, same thing. And then this is our initial venogram from the popliteal. You can see there's really no flow from our sheath, which is not unexpected given what we saw in the previous. Let's see. So then this is the tram track sign we talked about before with acute thrombus in the middle and the tram tracks on either side. You can see this is no vein wants to look like this. Okay, so what did we use in this case? It's something called the Inari clot triever. For those of you who are not familiar with it, this is about a 13 French sheath that you place in your access site, and this is this basket here. And what this does is it serves to capture the clot as you bring it back into the device. So what do I mean by what I just said? Well, through this goes a catheter which reveals, when you pull it back, this sort of coring mechanism here and this basket over here. So you literally get to the point right above the DVT, and then you start pushing forward, and this apparatus here moves forward up into the IVC, and then you drag the whole thing back. It captures the clot in that basket, and then it brings it into this here, and then you capture the whole device and bring it out, and then you can get all your thrombus out. So that's what we did multiple times in this case. This is the device here. You can see this is the coring element, and the basket goes from about here all the way up there. And then we bring it back, and I don't think this is the best example of it, but you'll see I'm dragging it back here. And you can see it's sort of deformed, and it's got a lot of thrombus in it. We made about 4 passes, I think. And then this is what we had actually after the clearance of that clot. So pretty stagnant, but if you remember what the clot looked like before, and you can see that right here, this is that little basket at the end of the sheath that captures the whole mechanism. And then here is a little bit higher. So you can see that it's static, but it's starting to clear some clot. And then this is the DSA showing that when we inject, you have this lesion right here that's part of the reason why we're having difficulty. So next, we did the same thing as we did in the previous case, which is to stent that component, and this was our final venogram on the table. And you can see there's some reflux, but it does clear, and we were done. So this was a single session mechanical treatment without a drop of TPA being used. So an interesting avenue to explore. By no means is this going to be the future. Hope maybe it is, but we don't know yet. We don't have that data. So I just want to point out other devices that are used in this space. This is the AngioVac device. This is typically used for large clot in the IVC and going down into the iliacs. It's been used successfully in that case. You can see the amount of thrombus it removes. It's basically a veno-venous bypass with the filter in the middle that captures the clot. The Penumbra Indigo system has also been used successfully in DVT. This is the JEDI, which is the Indigo catheters use a powerful aspiration system. The JEDI actually breaks up clot as it enters the mouth of the catheter and allows the removal of that clot. People have also used the cleaner in the setting of DVT with concomitant infusion of TPA or a fibrinolytic agent. So I would say, in conclusion, the take-home messages from all these mechanical devices is that there are many options on the market. We often use them in combination with thrombolytics, either up front or for cleanup. Only one of these, I will point out, has been used in a rigorous randomized trial, the ATTRACT trial, which I spoke about earlier. There's no clear best product at this time, and while there is some preliminary success and promise, I think there's a lot of work to be done to figure out how and when to use these devices. Thank you very much.